Welcome back to Doctor's Desk. Today we begin our discussion on shock, a critical life threatening state that forms the foundation of intensive care medicine. So, this session is structured on Harrison's Internal Medicine, Chapter 314, and will cover the physiology, classification, evaluation, and treatment of shock in a stepwise and in a clinically relevant manner. So I have made a concise PPT on it. So we'll see on it. So what is shock? Shock uh, it is a clinical condition of organ dysfunction caused by an imbalance between oxygen supply and oxygen demand. The result is tissue hypoxia, which is which, if uncorrected, progresses to irreversible organ injury and death. So it's basically imbalance between oxygen supply and demand, and this leads to cellular hypoxia, and then tissue injury, then multi-organ dysfunction. This stage is irreversible phase of shock. So before going into stages and determinants, we will see about the pathophysiology. So pathophysiology of shock revolves around inadequate oxygen delivery to the cells. So, under normal conditions, oxygen is utilized by mitochondria for oxidative phosphorylation and generating ATP. In shock, this pathway fails. So, in shock, the ATP generation fails, and the cells are forced into anaerobic glycolysis, producing lactate with uh, ATP depletion. So this ATP depletion leads to sodium pump ATPase pump failure. Then there will be ionic imbalance, and this leads to cellular swelling. So I have written it over here. So there will be decreased ATP, energy failure, increased lactate due to anaerobic glycolysis. This causes metabolic acidosis, then sodium potassium pump failure. This will cause ionic imbalance and cell swelling. Then there will be calcium influx, which causes phospholipase or protease activation. Um, so actually, calcium influx activates destructive enzymes like phospholipase and proteases. Then this cascade damages the cell membranes and activates inflammatory pathways and setting the stage for multi-organ dysfunction. So, so oxygen delivery is mathematically expressed as cardiac output multiplied by arterial oxygen content. So cardiac output depends on heart rate and stroke volume, um, which in turn are influenced by preload, afterload, and contractility. This arterial oxygen content is determined by hemoglobin concentration, then oxygen saturation, and small contribution from dissolved oxygen. So this any dearrangements in these parameters, there will be cardiac dysfunction, and critically these things reduce the determinants of oxygen delivery, and this precipitates shock. So there is a classification of shock which is distributive, cardiogenic, obstructive, hypovolemic. In Harrison, they would have given the uh, table where you can see the examples of shock. So distributive, you can see there is septic shock, pancreatitis, severe burns, anaphylactic shock, neurogenic shock, then endocrine shock, then adrenal crisis. In cardiogenic shock you can see myocardial infarction, myocarditis, arrhythmia, valvular causes like severe aortic valve insufficiency and severe mitral valve insufficiency. In obstructive shock, you can see tension, pneumothorax, cardiac tamponade, pulmonary embolism, constructive pericarditis, aortic dissection, and hypovolemic. It's usually the hemorrhagic causes like trauma, GI bleeding, ruptured ectopic pregnancies, and then GI losses, burns, polyuria like diabetic ketoacidosis and diabetic insipidus. This is the actual physiology and etiologies of each shock. So next we'll go into the hemodynamic profiles of each shock. Each type of shock has a characteristic hemodynamic signature. For instance, you can see the distributive shock has a lower systemic vascular resistance and high cardiac output, and less pulmonary capillary wedge pressure and less central venous pressure. So while the cardiogenic shock shows increased systemic vascular resistance, increased pulmonary capillary wedge pressure, increased central venous pressure, but decreased cardiac output. So each shock has a different characteristic hemodynamic signature. If you're good at this, you can find what shock is going on with the patient. So before going into evaluation of the patient with shock, we should know about the stages of shock. We should know where the patient lies, in which stage. So the shock progresses in three stages. In compensated, there is compensated, decompensated, and irreversible shock. In compensated shock, which is pre-shock, you can see tachycardia, vasoconstriction, and preserved BP seen in compensated shock. Whereas in decompensated shock, you can see hypotension and organ dysfunction become evident. So if still uh, untreated, then irreversible shock develops with profound cellular injury and death despite supportive measures. So next comes the evaluation of the patient with shock. First, we have to take the history of the patient, whether it is infection or trauma or chest pain or bleeding or drugs, anything it can be. And on examination, you can see I have told you in the previous slide, like you can see tachycardia in compensated phase, whereas in hypotension and decompensated phase. So it depends on the stages of shock. So cold extremities, tachycardia, altered mentation. Then other clues like elevated JVP and muffled heart sounds suggest cardiac tamponade, and while pulmonary crackles suggest cardiogenic shock, and in septic shock, the skin may paradoxically feel warm due to vasodilation. So next comes the laboratory and imaging evaluation. So Harrison has given the initial laboratory evaluation of undifferentiated shock. When a patient presents with a shock, our evaluation must be rapid but structured. The most important single test is lactate. So the marker of tissue hypoperfusion, where I told you that why lactate happens is because there will be switch to anaerobic glycolysis. So there will be increase in lactate, and eventually it causes metabolic acidosis. So which reflects tissue hypoperfusion and predicts mortality. Then renal and liver function test shows organ injury from hypoperfusion. Then cardiac enzymes helps identify MI or myocarditis. Then CBC reveals anemia, leukocytosis, or thrombocytopenia. The coagulation profile detects disseminated intravascular coagulation or coagulopathy. And in women of childbearing age, beta HCG must be checked to rule out unruptured ectopic pregnancies. Then ABG usually shows metabolic acidosis with elevated lactate. For bedside imaging, ECG reveals arrhythmia or ischemia. Then chest X-ray shows pneumonia, pulmonary edema, pneumothorax, and other things. Then POCUS. This POCUS means it is bedside echo plus imaging of IVC assessment, which shows the volume status. So then lung ultrasound detects pneumothorax or pulmonary edema. Together, all labs and imaging allow us to diagnose both type and severity of the shock. So the key principles of treatment is recognize the shock early, then assess for the type of shock present, then initiate the therapy simultaneously with the evaluation into etiology of shock, then involve all members of the multidisciplinary team, like we have to call the internal medicine team and surgical team to involve in this treatment. The aim of the therapy is to restore the oxygen delivery, then identify the etiologies of shock that require additional life-saving interventions. Then, so the initial treatment of shock is aggressive and time critical. So we should establish an IV or a central venous access to start oxygen and resuscitate with fluids. In septic shock, at least 30 ml per kg crystalloid is uh, early recommended early. If hypotension persists, norepinephrine is the vasopressor of the choice. In shock, then when infection is suspected, broad spectrum antibiotics must be administered within the first hour. We'll be seeing about the empiric antibiotics in next episode. So every delay increases the mortality. So there is a shock type specific management. So each shock has each specific management. So for distributive, you can see in septic shock, we should start with early IV fluids like 30 ml per kg crystalloid within 3 hours. Then with broad spectrum antibiotics and vasopressors like norepinephrine and source control like drain abscess and remove the infected catheters or the dressings. Then in anaphylactic shock, intramuscular epinephrine should be administered 0.3 to 0.5 mg, and airway must be protected because in anaphylactic shock, uh, the laryngeal swelling will be evident. So before it gets swelled up, we have to protect the airway. So if we don't, then the patient might end up with obstruction for airway. Then we have to secure an IV and give fluids and antihistamines and steroids. In a neurogenic shock, we give fluids and vasopressors and maintain the spinal cord perfusion. In adrenal crisis, we give IV hydrocortisone 100 mg, then fluids and vasopressors. Then in cardiogenic shock, we give oxygen and non-invasive or invasive ventilation as needed. In acute MI, we should go for urgent PCI or thrombolysis, then inotropes, and avoid fluid overload, which can lead to pulmonary edema. Then mechanical support, if refractory to these managements, like as I said in my previous videos, like ECMO and all. Then, then in hypovolemic shock, the priority is fluid replacement. In hemorrhagic cases, transfuse blood products and stop bleeding surgically or endoscopically. In non-hemorrhagic cases like diarrhea, burns, or DKA, crystalloids and correcting the cause are sufficient. So finally, obstructive shock, the only life-saving option is to remove the obstruction. Do the immediate needle compression for tension pneumothorax or pericardiocentesis for cardiac tamponade. Then thrombolysis or embolectomy for massive pulmonary embolism, and surgical or endovascular repair for aortic dissection. So, thus, the management must be specific and tailored. Fluids for hemorrhage and revascularization for MI, and antibiotics for sepsis and decompression for time. That's all the essence of treating the shock. So, in summary, to summarize, the shock is a syndrome of inadequate oxygen delivery, manifesting as organ dysfunction. It is classified into four main types, each with characteristic hemodynamics and management. The stages progresses from compensated to irreversible. The keys to survival are rapid uh, recognition and restoration of oxygen delivery, and type specific interventions is needed. So yeah, thank you, and do subscribe to Doctor's Desk.